Hello, everyone. It is my honor today to give this presentation on behalf of the Director of the Africa Centers for Disease Control and Prevention on tracking viral hepatitis in Africa. And as an alumni of the first COLDA that took place in 2018, it is really my pleasure to be here once again and to contribute to this really important conference. So this is the outline of my talk. And I will begin by talking about the reasons why we need to be tracking viral hepatitis. So this slide is really a refresher for all of us. We know this information, we're very familiar with it, but it's always good to go back and reaffirm the reasons why we need to be conducting viral hepatitis surveillance. So there are different reasons and there are different ways in which we can conduct surveillance on the continent. And these different ways that we conduct this surveillance provides us with different forms of data that have specific use. So surveillance for acute hepatitis, for example, will help us detect outbreaks, but also monitor trends in incidence and also identify risk factors for new and incident infections. And surveillance for chronic infections will help us estimate prevalence of these chronic infections, monitor trends in central groups, but also identify high-risk groups and also areas within countries, for example, that where elimination efforts need to be focused. And surveillance for cirrhosis and HCC really help us estimate the burden of the long-term consequences of chronic infections. So importantly, all these data help us to evaluate the feasibility, the cost effectiveness, but also the impact of different types of prevention and control programs. So for example, when you conduct surveillance of type-specific acute hepatitis, the data can be used to evaluate the impact of programs that prevent new infections. So for example, for Hep A, you could use the data to assess the impact of Hep A immunization, but also of food and water safety, for example. And for Hep B and Hep C, you could use data on acute hepatitis incidents to assess blood safety. And when you conduct surveillance for chronic Hep B and Hep C infections, this data can be used to evaluate the outcome of universal Hep B immunization, for example, but also programs that prevent and control, Hep B and Hep C infection through injection safety, blood safety, infection control, harm reduction. And also we can use this data to assess programs for testing and treatment of Hep B and Hep C infection. And obviously when we talk about surveillance with the long-term consequences, and evaluating the impact of prevention and treatment programs and assessing specific mortality of these programs is possible. So importantly, this data can also provide us with the cost effectiveness of introducing new interventions such as the birth dose vaccine. And also they can provide data to support evidence-informed policy and planning. So all of this together really helps us to influence our politicians and to provide them with the helpful data that they need to implement the policies that are required. But this also helps, this sort of data also helps to inform public health officials on where to focus elimination efforts for viral hepatitis and where there is a gap, where efforts need to be concentrated. And these data also importantly can be used to provide evidence that supports introduction of prevention and control measures, not only in the country where this surveillance is being conducted, but also in neighboring countries that have similar epidemiological features. And as this data provide evidence on disease burden, they can also be used to assess budget implications when developing operational plans during the implementation of national hepatitis plans, and when approaching funders for advocacy, and when estimating what domestic funding needs to be allocated for elimination efforts. So briefly now on viral hepatitis surveillance in Africa. So as we all know, there is a high disease burden on the continent. There are 82, and these are estimates that we have, right? 82 million that are infected that are living with Hep B and 9 million with HCV. However, these are only estimates. And the problem is that a very low number of Africans are actually aware of their Hep B and Hep C status, except in some countries such as Rwanda and Egypt, which have a very well developed screen and treat programs for Hep C. However, in the majority of countries, these are not implemented. And this percentage is way below the 20% target set by WHO for 2020. And there is obviously a lack of population-based surveys in most countries, if not all. And this has led to some serious discrepancies in modeling data that has been reported recently. So the next few slides will be on how we can build capacity to track viral hepatitis on the continent. So first of all, we need to make an inventory of what is already there. And this again is, the idea that, there's no need to really reinvent the wheel. And this slide simply serves to show that as much as there's been enormous disruption during the COVID-19 pandemic, there has also been enormous capacity building. And this slide is already outdated. As you can see, by August 2020, all countries, through efforts by WHO, by Africa CDC, and by different partners such as BMGF, all countries on the continent had molecular diagnostic capacity for COVID-19. And this is by August 2020. By now, one whole year later, this capacity has probably doubled. But we really need to make sure that we are mapping these resources and we make sure that these resources are used efficiently, even beyond the pandemic. So for countries where partners will come in to support specific aspects of our hepatitis programs, including surveillance, it's important to understand what is already there in terms of national plans and programs for viral hepatitis, understanding which stakeholders are already present on the ground and are supporting elimination efforts, including screening and surveillance. And this can range from CSOs, from NGOs, public-private partnerships, just as an example. And understanding what is the existing capacity for surveillance for infectious diseases. And this goes beyond viral hepatitis. This should include all STIs, because then we can integrate viral hepatitis surveillance in surveillance systems that are already present for other diseases. And also understanding that there is political traction for reaching elimination goals, so that these programs that we come and support countries with really become country-owned, country-led, and country-funded. The second priority is to make sure that there is an initial estimate of the prevalence of Hep B and Hep C in the general population, and also in special populations, depending on the local epidemiology, obviously. And a survey may need to be conducted to assess this. And this is where we really recommend using historical samples or integrating these surveys with existing population-based surveys. And as we know, several countries are already doing demographic and health surveys, and several are also doing the population-based HIV impact assessment that will really give an idea of the prevalence of Hep B and Hep C in the general population and in different age groups. And where historical samples have not been previously collected, and where these surveys need to be now implemented, we really need to make sure that countries are benefiting from the experience of countries that have already done these sorts of surveys and really make use of best practices and lessons learned. And this is where communities of practice come into play. The third priority is to examine what is already in place in terms of surveillance for acute and chronic hepatitis, and to really see how these systems can be optimized. For example, we can also set up sentinel sites for biomarker testing and for collection of epidemiological data, because we need to understand what risk factors are specific for these infections. But importantly, we also need to make sure that this surveillance is also linked to the capacity building of healthcare professionals, both at the laboratory and in the clinic. And the approach that we preconize is really the trainer of trainers approach, so that these sort of training can be rolled out at national level. Finally, one of the weakest links in this chain is usually surveillance for the long-term consequences of viral hepatitis, of chronic viral hepatitis infections. And this would be cirrhosis and HCC. And here again, the recommendation from different guidelines is to really make use of resources that are available in country for this form of surveillance and linking with cancer registries and vital registration. But again, this should be linked with training of healthcare professionals involved in the whole continuum of care, all the way from diagnosis to clinical management and palliative care. Because as we know, patients very often they present too late to be treated. So we really need to make sure that all these patients are taken care of. So lastly, a little bit of self-promotion. I'm going to very briefly mention some Africa CDC activities that we are planning around this tracking viral hepatitis on the continent. And again, we want to conduct a situational assessment in all our member states to understand the capacity that is already there, and all the capacity, all the plans, everything that's already in place, and how we can fit in and support them with reaching elimination goals. We also want to conduct sero surveys in 5 member states that will be identified based on the data obtained from the situational assessment, and also set up sentinel surveillance in 5 member states and conduct capacity building for up to 1,000 professionals working in the field of hepatitis, all the way from diagnosis to case management to palliative care. There are some activities that we have planned, but that are not yet funded. And these are really the idea of conducting genetic studies and leveraging on some of the capacity that we have at Africa CDC, including Africa CDC Genomics Institute, to conduct genotyping of variants and identify any vaccine escape mutants, but also drug resistance. Also use the Africa CDC Community Healthcare Worker Program to raise awareness on viral hepatitis and increase, obviously, advocacy for screening, but also timely vaccination so that mothers can request birth dose vaccines for hepatitis B for their children. And when we're talking about all of this, including screening and vaccination, we also thinking about pooled procurement and want to leverage on the African Union African Medical Supplies platform that was set up for COVID-19 supplies and diagnostics, and really try again to make use of this platform beyond the pandemic and make it available for procurement of diagnostics and drugs for viral hepatitis, to make it available to our member states. So we've come to the end of my presentation. Always happy to connect with partners and with collaborators. And for more information, you can contact me at this mailing address. Thank you for your attention.